Good morning, everyone. Today I'll be presenting a case study on acute septic arthritis of the knee caused by Streptococcus pneumoniae. I'll review the patient's history and the key laboratory findings and discuss the disease process and ultimately answer the assigned case study questions. Septic arthritis is an acute bacterial infection of a joint space. Because the joint is normally sterile, even a small number of bacteria can trigger rapid inflammation and cartilage destruction. It's considered a medical emergency, and patients typically present with severe pain, swelling, warmth, and limited range of motion. Common organisms are going to include Staphylococcus aureus and Streptococcus species, and the risk factors are going to include diabetes, immunosuppression, and pre-existing joint disease. So on February 3rd, our patient presented with worsening right knee pain, swelling, and a fever of 100.7. He had been evaluated previously for chronic right knee pain, but the symptoms had escalated over the week. An x-ray was done on January 26th and did not reveal a clear cause. As swelling increased and fever developed, he was referred to the emergency department for a joint aspiration. During the aspiration, the synovial fluid appeared brown, turbid, and runny, and lacking normal viscosity, which immediately raised concerns for infection. So a knee aspiration, or what we would call arthrocentesis, is a sterile procedure used to remove the fluid from a joint. So the skin's going to be clean, the area is going to be numbed, and the needle is going to be inserted into the joint space, usually into the suprapatellar pouch, which is just simply the upper pocket of the knee where the fluid collects when the joint is swollen. So many clinicians are going to use an ultrasound to help guide the needle, especially when the swelling is deep or the landmarks are difficult to feel. Once the needle is in place, the synovial fluid is going to be withdrawn and sent to the lab for a cell count, gram stain, culture, and crystal analysis. Our patient also has uncontrolled diabetes, and uncontrolled just meaning that the patient's blood glucose levels are consistently above the recommended targets over time. And this is an important risk factor because chronic hyperglycemia is going to impair the immune function. All right, so let's go over our laboratory findings now, and we'll start with our CBC. You'll see on the screen that there's a synovial fluid smear. That's just going to be an example of what your synovial fluid might look like under the microscope. So our patient is showing severe neutrophilia with 93% neutrophils and an absolute neutrophil count of 29,000. And our reference range for that is going to be 1,600 to 8,000. So that's a lot. And our immature granulocytes are also present. So this is going to reflect a strong systemic inflammatory response with the bone marrow releasing neutrophils to rapidly fight that infection. Our chemistry panel is going to show mild hyponatremia. Our glucose is going to be 280, and this is consistent with uncontrolled type 2 diabetes and stress-induced hyperglycemia. There's going to be highly elevated AST and normal kidney function, which is going to be important for antibiotic dosing. Next are inflammatory markers, and our CRP tested at 259, which is extremely elevated and consistent with bacterial infection. And an elevated CRP just means that the liver is releasing large amounts of C-reactive protein because the body has significant inflammation. All right, next we're going to go over our synovial fluid findings. As we can see, the appearance is brown, turbid, and runny. This just means that the infection is breaking down the hyaluronic acid and making the fluid thin and cloudy. And our nucleated cells tested at 700,000, and the normal limit is normally below 200. And just for reference, we can see in this chart that inflammatory conditions such as rheumatoid arthritis and gout are going to have a cell count, a nucleated cell count of 2,000 to 50,000, and our septic arthritis range is going to be over 50,000 cells, often between 100,000 and 500,000. But our patient tested at 700,000, which is extreme and strongly supports a pyogenic infection. All right, let's go over the rest of our CBC findings. Next, we're going to look at our red blood cells, and we tested at 300,000. So essentially, there's supposed to be no red blood cells in a healthy synovial fluid, and even 1,000 is already considered bloody contamination. So 300,000, this is massively above the normal range and much higher than the typical traumatic tap ranges. So this is going to tell us that the joint is inflamed and damaged, that the synovial lining is bleeding, and that the infection is severe enough to disrupt the tissue integrity. Next, we found no crystals in our specimen, which is really good. Here is 2 examples of crystals that we could find in gout and pseudogout, but we did not find any here, so that's going to rule those 2 conditions out. Lastly, let's go over our microbiology results. For our gram stain, we got 4+ PMNs and 4+ gram-positive cocci in pairs and chains. So our morphology is going to be consistent with Streptococcus pneumoniae, and our culture also showed heavy growth of Streptococcus pneumoniae. And so this is going to confirm the causative organism. Something I wanted to clarify about the synovial differential in the CBC. The synovial differential reported mostly mononuclear cells, while the CBC showed a neutrophil dominance, and this seems contradictory until we consider the gram stain. In septic joints, neutrophils break down quickly due to the bacterial toxins and enzymes, and once they lyse, they lose their normal morphology and can no longer be counted on the differential smear. Mononuclear cells survive longer, and so they become overrepresented. The gram stain, however, can still show intact and partially damaged neutrophils, which is why it was reported at 4+ PMNs. And so ultimately, this means that the joint is truly neutrophil rich and that the differential simply undercounted them. Lastly, let's look at our tissue and blood culture findings. Our surgical knee specimen also showed gram-positive cocci in pairs and grew like Streptococcus pneumoniae. Our blood culture bottles were both positive, confirming bacteremia. And lastly, the susceptibility report shows that the organism is susceptible to penicillin, ceftriaxone, levofloxacin, vancomycin, and clindamycin, but resistant to erythromycin. All right, so we've made it to our discussion section, and I'm also going to be going over the case study questions and the answers to those. So all of our laboratory findings support acute bacterial septic arthritis, the extremely high WBC count, the purulent appearance, the positive gram stain, and the culture results confirm a severe infection caused by Streptococcus pneumoniae. Although pneumococcal septic arthritis is less common than staphylococcal infections, it is more likely in patients with underlying conditions. And we do see that our patient has uncontrolled diabetes and interestingly has a past history of pneumococcal sepsis. So ultimately, this is going to increase our susceptibility to invasive pneumococcal disease. Our diabetes is going to impair the neutrophil function and circulation, making it harder for the body to clear this bacteria. The most likely route of infection is a homogeneous spread, where bacteria enter the bloodstream first and then seeded into the knee joint. Next, we're going to go to our questions and answers to the case study. Number 1 question, how do the synovial fluid results help differentiate septic arthritis from gout or pseudogout? And we went over a little bit of this earlier, but just to reiterate, there were no crystals seen, which helps rule out the gout and pseudogout. The extremely high WBC count, purulent appearance, and the presence of bacteria on the gram stain and the culture all support septic arthritis. The purulent appearance especially is important because pus forms when the neutrophils are actively fighting the bacteria, and pus is made of neutrophils, bacteria, and cellular debris, whereas crystal-related conditions are not going to produce pus. Question number 2. How do the blood culture and susceptibility results guide the antimicrobial therapy? So positive blood cultures confirm a systemic infection requiring IV antibiotics, and the susceptibility profile shows that the organism is sensitive to penicillin and ceftriaxone, which are appropriate first-line choices because they target the bacterial cell wall synthesis in gram-positive organisms like Streptococcus pneumoniae. And our last question is going to be, how does the patient's diabetes contribute to the severity of the infection? And we went over this as well a little bit. So the uncontrolled diabetes is going to impair the neutrophil movement and function. It's going to reduce chemotaxis. It's going to slow down the circulation, and it's going to increase the susceptibility to invasive infections, ultimately making septic arthritis more severe and harder to control. So in conclusion, this case study demonstrates a severe pneumococcal septic arthritis of the knee. The diagnosis is supported by a synovial fluid appearance, gram stain, culture results, and positive blood cultures. Because the patient also had bacteremia and uncontrolled diabetes, rapid treatment was essential. Management typically includes 2 to 4 weeks of IV antibiotics and repeated joint drainage. With timely therapy, most patients will recover their joint function, though some may experience long-term stiffness. And that is the conclusion to my case study. Thank you.